I am Jang Kim from the Catholic University of Korea. Thank you for inviting me here. Today I'm going to show you the recorded live case about endovascular treatment of a right SFA, chronic total occlusion supported by intravascular ultrasound. 68-year-old man presented with a claudication in right legs. He underwent endovascular treatment of a left SFA due to toe gangrenes 1.5 years ago. He has a diabetes mellitus, hypertension, dyslipidemia. He was ex-smoker with a six-pack year. Ankle brachial index were 0.3 in right leg and 1.02 in left leg. CT angiogram showed the right SFA chronic total occlusion and tandem iliac artery stenosis. The patient was sent to the hybrid room and skin preparation was done in left groin. Crossover retrograde approach from left to right femoral artery was done for revascularization. Angiogram showed the right SFA chronic total occlusion from the beginning. O35 Rubicon catheter and straight Traumaglide wire was used for engaging a CTO stump. And was able to be advanced into mid-SFA. Even after multiple attempts of catheter and wire to enter the distal SFA, angiogram still show dissections without distal runoff, which means re-entry failure. So, ultrasound-guided distal SFA puncture was performed with microneedle. V18 wire was able to be advanced with proximally without problems. V18 wire was captured in right common femoral artery with a 10 mm amperage gooseneck snare, and re-entry was completed finally. After checking the angiogram of SFA, pre-balloon was performed by installing PTA balloon 4 mm, 15 cm for easy passage of IVUS catheter. Then IVUS was performed. We used OptiCross 18 peripheral image catheter from the Boston Scientific Company, which can see maximum 12 mm vessel in diameter. Initially, we recorded IVUS image by automatic pullback method. And then we evaluate SFA lesions with the transverse and longitudinal view carefully. We check the wire location to confirm the subintimal status and diameter of artery along the CTO lesions. Diameter of SFA was around 6 millimeters, which was larger than diameter from the angiogram. For proper vessel preparations, stalling PTA balloon 6 millimeter 15 centimeter was inflated from the distal to proximal SFA 3 minutes for each session. And then we checked again SFA CTO lesions with IVUS. IVUS showed the recanalized CTO lesions along PTA side. But we found that residual distal SFA dissections was left with the flow limitations. So we decided to balloon around the residual dissection area again during DCB inflations. 5 millimeter 20 centimeter Ranger drug coating balloon was inflated from the distal re-entry site to open flow limiting dissection area, and then 6 millimeter 15 centimeter Ranger drug coating balloon was inflated again to proximal SFL lesions 3 minutes 6 ATM for each session. After completion SFA revascularization, 7 French ancellus was withdrawn to proximal right iliac artery, and then angiogram was performed. There was a tandem stenotic lesion which was stented with EPIC 9 millimeter 8 centimeter self-expanding stent. Final angiogram in iliac artery was done, and then another angiogram in right SFA was done. Flow of both lesions were quite patent. Puncture site was closed by manual compression method after closing device was failed. Ankle brachial index after percutaneous angioplasty of right SFA was increased from 0.3 to 1.04.